We're going to do a general poison review. We'll talk about pharmaceutical ingestions and then environmental ingestions, and then we'll talk about emergency topics, various potpourri, emergency medicines, kind of anything that doesn't fit in any other category kind of neatly they throw over to me. I will note, and I left it this year, eventually probably I will take these out, but it used to be that the content specifications for the board review were very specific. They would say, know the symptoms of a clonidine overdose, not just know about clonidine overdose. And so I took those questions and I actually framed the specific answers to those questions in previous years. I framed them in the triple exclamation points there. And so I still left those in there. The content specs don't do that anymore. I guess they got smart and they'll list clonidine as a, having to know about clonidine overdose. So they don't get that specific anymore. So I can't guarantee that those are things that you can hone in on, but certainly previous years, those are things that they were interested in. Well, let's start with poison review. I like the quote, the surest poison is time. Who gets poisoned? The review of poisoning in the United States is always a couple of years behind in terms of the report because it takes a while for them to collect the data. And so from 2010, which was this year's report, there were 2.4 million events, and almost 50% of them were less than 66 years of age. Peaks are 1 to 2 years of age, so pediatric age group. Majority occur at home. Fortunately, the majority involve one substance, and most of them aren't very serious, and they can be managed at home. The most common poisons, we have two groups, the less than 5 years of age and then the adolescent ingestions. As far as the adolescent ingestion go, about a quarter of them are intentional. The more common ones are acetaminophen, antidepressants, alcohol. And then for the pediatric less than 5, we see this list here: cosmetics, lipstick, mascara, analgesics, cleaning substances, and then you can look at the list. What I find to be interesting, just of note, cold and cough preps. I've been doing this lecture for quite some time now, and cold and cough preps used to be like 4 or 5. And since the AAP several years ago gave the recommendation about cold and cough medicines, you see it dropping down the list. I assume that people don't have it in their homes as much. Well, how do we care for pediatric ingestions? For the most part, if you think of it as a non-toxic ingestion, you should tell the family to call poison control. Most of the kids get observed at home. I'm going to mention Ipecac because that used to be a big thing many years ago. Again, 3/4 of these can be handled at home, and then obviously all the others need to be evaluated either in the office or ED. You should know that one of the resources that you have is your poison control center. It's good for ingestion identification, dosage toxicity, how much is really going to harm this child, signs and symptoms of toxicity, recommendations for home care, and recommendations for if I have a difficult ingestion in the ED and we don't have a toxicologist immediately available at our hospital, I can call poison control and they can give me management recommendations. Poison prevention, and I'm sure you'll get this in your preventative pediatric portion of your lecture in terms of anticipatory guidance, but you should discuss the storage of poisonous substances at the 6-month-old or 6-month well child visit just before the child gets mobile. The other thing they wanted you to know about was that there are a number of different poison preventive efforts that have had a significant impact in the years, not just education, but other things in the years to decrease the amount of poisoning. One of those particularly is child-proof caps. Well, let's hit the meat of the lecture, which is approach to the poison patient. Now, this is going to be initially an unknown poison, because those are the ones that are the most difficult. So you have someone come in who took something, whether it be a pill, he's acting funny, you think that the child has an ingestion. A little bit different than, okay, he ate 5 acetaminophen pills. The first thing we want to talk about is how to identify the poison, and certainly your history, your physical. I want to talk just a little bit about toxidrome and testing, and then we'll talk about treatment, which is pretty standard and straightforward in terms of ABCs, etc. Well, let's talk about history. Fairly straightforward. What? The parents may need to do a search of the home or the grandparents' home. Have them bring the container if possible. Do a medicine cabinet manifest. I see i.e. what's in the medicine cabinet. When was a child unobserved? When could he have taken this is important in terms of when to expect symptoms. How in terms of route exposure. How much. Just of note, we always look for the worst case scenario because you obviously don't want to underestimate the amount of substance ingested. So I always, if there's 10 pills missing, I assume the kid took 10 pills. Of note, in terms of liquid medicine, the average swallow of a young child is about 5 to 10 cc's. Of an older child is 10 to 15 cc's. So if they come in and say, I only took a swallow, you can get a guesstimate as to about how much volume that is. In terms of physical exam, there's other things that are helpful: heart rate, respiratory rate, blood pressure, neurostatus, pupillary findings, breath, odor, skin temperature, color, diaphoresis. I gave you a few mnemonics here that if you're really into poisoning, you can memorize that would be helpful in terms of identifying unknown poisons. Specifically, if you have someone showing up with a fast heart rate, they're tachycardic, the mnemonic FAST, F-A-S-T, free-base cocaine, anticholinergics, sympathomimetics, and theophylline are the four that you should think about. For a slow heart rate, propranolol is probably the one that we see most common. Anticholinesterase drugs, clonidine is another one that we see commonly, ethanol, and digoxin. And that mnemonic is PASTE. If you have someone that shows up with small pupils, COPS is what I use, and I don't even know if this show is on anymore on Fox, but COPS is the mnemonic we use. Cholinergics are clonidine for the C. Opiates are organophosphates, phenothiazine, pilocarpine, sedatives. Those all will give you small pupils. And then for large pupils, there's not a real good mnemonic for it. AAAS is what I use: antihistamines, antidepressants, anticholinergics, and sympathomimetics. Finally, we can talk about other things in terms of skin findings. Diaphoretic skin, you can have sympathomimetics, organophosphates, salicylates, and PCP. Red skin, the one everyone thinks about is carbon monoxide. That's actually a cherry red skin. That's not real common in carbon monoxide poisoning, but I did include it on the list. Anticholinergics, and then blue skin methemoglobinemia agents. Wanted to talk just a minute about toxidromes. A toxidrome is a collection of those symptom complexes associated with a specific toxin. So one of the more common ones for anticholinergic or phenothiazine overdose is the blind as a bat, hot as a hare, red as a beet, dry as a bone, mad as a hatter. So you have large pupils, fever, flushing, decreased sweating, decreased urination, delirium, and hallucination. So you can use a toxidrome to help figure out what substance was ingested. In terms of testing, if you know the specific poison or if you have a suspicion, there's a few that will be helpful, but in general, just drug screens in and of themselves usually are not very helpful for diagnosis and treatment. They're usually confirmatory. Certainly drug levels for acetaminophen, a salicylate, or ethanol, certainly those are helpful, but most of the time the drug screens in and of themselves are not helpful. Another tool you can use is a radiograph. There are occasionally pills that are radio-opaque. The mnemonic for this is COINS. Chlorohydrate, opium, iron, neuroleptic agents, and sustained release agents may show up on an X-ray. So that's another tool you can use, especially for a small child if you're looking for a radio-opaque substance. And then finally, ECG is the other laboratory test. You can see some changes from cardiotoxic drugs, i.e. in tricyclic ingestions, you'll sometimes see a prolonged QRS. Certainly CBC, renal pan, LFTs, osmos, those can be helpful. If you have someone that has a low blood sugar, they may have altered mental status, low blood sugar. Hypoglycemic agents sometimes can cause low blood sugar and therefore be the cause of your altered mental status and ingestion. Specifically beta blockers, insulin, ethanol is probably for pediatrics one that you need to remember, salicylate. I don't include a lot of basic science in my lecture. I include a lot of clinical tips and clues. I did want to mention a couple of calculations to you, specifically your osmolar gap, which is the measured minus the calculated osmoles here. So you measure your osmol and then you calculate your osmol via the formula here. If you have a gap greater than 10, that will identify an unknown alcohol ingestion, specifically methanol, ethylene glycol, diuretics, isopropyl alcohol, or ethanol. The mnemonic for that is me-die. I didn't make that one up. I got that from someone else. Finally, the other one besides the osmol gap you can use is your anion gap. You may remember that. Now, these numbers, I use greater than 12. You sometimes see a little bit different numbering. You can see 10, 11, the same with the osmol, but I use greater than 12. And mud piles, you may remember that from med school in terms of the cause of a large anion gap. And that the gap is essentially your sodium minus your chloride plus your HCO3. And the more common ones that we look at are that we're going to talk about today that may cause a high gap are iron, ethanol, ethylene glycol, and salicylates. Obviously, you can do a ABG to determine your acid base status, but in terms of identifying the patient status and the ingestion, those are the laboratory tests that you should use. Well, let's move on and talk a little bit. We're talking about an unknown ingestion here in terms of poison treatment, and this is essentially for all patients. You know, you start with airway, breathing, circulation. So I've included all that there. Most of the time, fluids and anatropes are just as needed. For ingestions, is a little bit special piece in terms of getting to the D when we look at decontamination for skin or GI ingestions, and don't, which is dextrose, oxygen, naloxone, and thiamine. Obviously, the dextrose is for patients who might be hypoglycemic, O2 for hypoxemic patients. Narcotic overdoses get Narcan, and then thiamine for ethanol abuse. We don't usually see that in pediatrics, but I did include it. Let's move on and talk about decontamination. For dermal decontamination, you should remove the clothing and wash the skin with water and then soap with water. Obviously, you should protect yourself at the same time if it's a toxic substance. For ocular exposures, the solution to the pollution is dilution, i.e., you want to make sure that you irrigate the eyes with copious amounts of normal saline. We actually switched, I left this, we actually recently switched to lactated ringers, just as note, because the pH is a little bit better. It doesn't sting the eyes as much as saline does. And respiratory, obviously, move the patient to fresh air. Shouldn't be a problem if the patient's in the ED. GI decontamination is probably one of the most common things that we'll use, but we use it actually relatively uncommonly. Most liquids are absorbed within 30 minutes, and most solids are absorbed within 1 to 2 hours. You know, our choices are ipecac, gastric lavage, activated charcoal, and cathartics. Those are the four main choices we have. I'm not going to talk about whole bowel irrigation. That's for special ingestions. You sometimes can consider that. I mentioned ipecac because it was on the contact specs for a long time. It used to be in the 80s and previously that you had ipecac at home. You were recommended to give ipecac at home if your child ingested something. You caused poison control. They would tell you to give ipecac. These kids would come in vomiting. Or if they presented to the ED, we would give them ipecac. Well, evidence-based medicine came along, looked at the practice, and actually figured out that ipecac really wasn't that effective in terms of preventing hospital admissions, significant side effects, etc. So we feel that it's ineffective, no home use, rarely used in the hospital situation, and you can see here 0.02% of ingestions received ipecac. If you have a very, very large, very, very toxic ingestion without any other therapy, it may be of some benefit if you get it quickly. Activated charcoal. Now, we do use this still for some of our patients, but again, only 3% of the ingestions in 2010 received activated charcoal. The idea with charcoal is that it absorbs the ingested substance and decreases bioavailability. We think there may be some benefit if the patient has ingested a potentially toxic amount within the past hour. In special situations, they sometimes will even consider giving Q4, Q6 doses or repeated doses. Complications with activated charcoal: pulmonary aspiration, emesis, constipation, Contraindications, hydrocarbons, corrosives, ileus, compromised airways. These are the drugs that you would not want to use or you would not want to use activated charcoal with. And if you think about it, things you find in your garage generally are not things that charcoal is going to be effective for. Things you find in your medicine cabinet, charcoal may have some benefit for. Now, there are a few exceptions to that, iron pills being one of them. But that's how you can kind of get an idea of whether charcoal may be helpful or not. Gastric lavage. Used to be, teenagers came in, they got a nose hose, got their, quote, stomach pumped out, and we do that very, very rarely these days. Usually only do it in older children and adults if it's within a very short time since the life-threatening ingestion. And by the way, if you lavage someone out and you don't get any pill fragments, it's not a diagnostic test, meaning that just because you didn't get pill fragments doesn't mean that they got a didn't get a toxic ingestion. There's obviously complications to this in terms of pulmonary aspiration. There are definite contraindications, acids and alkalis, sharp ingestions, altered mental status. We don't usually gastric lavage people very much anymore. Cathartics, not commonly used either. The idea is if you add a cathartic, it may decrease the GI transit time, i.e. decreasing absorption and decreasing bioavailability. A cathartic alone is never recommended. There really isn't any studies to show improved outcome. So the routine use is generally discouraged. Well, those are the tools that we can use for patients who have an ingestion. Now I'd like to go specifically to the specific ingestions, and we'll start with the pharmacy and talk about acetaminophen, which if you're going to get one on your test may be the most likely one because it's one of the more common ones. It's obviously one of the most commonly used analgesics. It's very rapidly absorbed, peak plasma levels within about an hour. It's metabolized in the liver using glutathione, and this is the normal pathway of metabolism where you get a non-toxic metabolite. What happens in a acetaminophen overdose is that the glutathione stores here get depleted. And because they get depleted, you can no longer go down the regular pathway, and therefore it produces toxic metabolites and causes significant liver necrosis. So this is how acetaminophen can be a very significant toxin. I'm going to include, since I'm on the metabolism pathway here, I just want to include the treatment for acetaminophen overdose, if it is indicated, is to replace the glutathione stores so you have the normal pathway here rather than the toxic metabolite pathway. And we use N-acetylcysteine to replace those glutathione stores. So that's why you give N-acetylcysteine in certain cases of acetaminophen overdose, is to prevent those toxic metabolites. Well, what is a toxic overdose? Well, I'm going to concentrate on acute overdoses because those are the most straightforward. Minimum toxic dose is usually around 150 milligrams per kilo. That number can see various numbers in the literature, but 150 per kilo is one of the more commonly seen numbers. For adolescents and adults, commonly they'll use 7.5 grams. That's a little bit different than a chronic toxic dose. Obviously, you can take a subtherapeutic level, i.e. 150 per kilo for greater than 2 days. 4 grams a day for 2 days may put you at risk for a chronic toxic overdose. Well, let's talk about symptoms. In the first 24 hours, usually there's just GI symptoms. So you get GI irritation from all these pills in your gut. So you get nausea, vomiting. Your LFTs are going to be normal. The next 24 to 48 hours, you have a latent period, and that's essentially you've recovered from the GI irritation, and the toxic metabolites are doing their work. You may, during this time, have just a little bit of right upper quadrant pain. Your LFTs certainly may be rising. Then in 72 to 96 hours, you're going to get your hepatic failure where the toxic metabolites have done their job. You're going to get peak symptoms in terms of hepatic failure. You may have significant coagulopathy. And if you survive this with supportive care, then in 4 to 14 days, it's going to take you a while to recover. Usually the symptoms resolve if you can support them effectively enough. Well, how do we manage these patients? Well, activated charcoal, if it's within an hour of ingestion, still is recommended. We then use acetaminophen levels, and we have a nomogram that we use for, which is for single acute acetaminophen overdose. It's not for a chronic overdose. It's for a one-time overdose. And we usually like to measure take the first measurement, although you can do it earlier. The first measurement of the graph that's standard is at 4 hours post-ingestion. You should remember, while the patient's asymptomatic, just because they're asymptomatic doesn't mean that there's not anything happening. They certainly could be developing liver toxicity. So this is the Rumick-Matthew nomogram, and I want to explain this nomogram a little bit. So what you do is, this is your x-axis is your hours after ingestion, and then you have your acetaminophen level. At 4 hours post-ingestion, if you're in this area here, below the line here, then you're unlikely to have hepatic toxicity. And so usually therapy is not needed, and assuming that your history is appropriate, et cetera, normally you can send these patients home. If you're above this line, and especially if you're above the second line here, you have a 60% chance of hepatic toxicity. So what we normally do is, if you're above the lower line, or if you have significant symptoms, you're going to get treated. So and again, I want to remind you, this is not for chronic overdoses where someone's been taking a large dose for 3 or 4 days. It's for just a single acute episode. So what do we use? We talked about the N-acetylcysteine. For toxic levels or hepatic toxicity, you treat until the acetaminophen levels are near 0. ALT is normalizing and the patient is clinically well. They used to give N-acetylcysteine orally, and in fact, where I worked, we had a teenager who came in and says, "I like my with repetitive ingestions." She says, "I like my N-acetylcysteine with orange juice because it didn't taste very good." But they now have an IV form, used it in Europe first, now in the United States, and that's what we standardly will use. Ideally, you want to administer it within 8 hours of the ingestion. Certainly, if it's a little bit later in the course, I would consider administering it, but you like to get it within 8 hours. And then obviously follow your liver function studies and LFTs. Obviously, with acetaminophen ingestion, you should also consider co-ingestions, especially if it's an adolescent. Well, let's move on and talk about anticholinergic toxicity. Specifically, diphenhydramine is probably one of the more common ones. Symptoms, that toxidrome we talked about before in terms of hyperthermia, mydriasis, flushing, decreased sweat, urine, agitation, seizures. The treatment for anticholinergic toxicity is activated charcoal if the mental status is appropriate. It tends to have an increased GI transit time, and therefore activated charcoal may have some effect as opposed to other ingestions. Supportive care, in past they've talked about using physostigmine, but for the most part it is supportive care. Antihypertensives, clonidine. Clonidine is one of those things that is given very commonly and is found commonly in the home, and that we still see in the emergency department. Why it's such a big deal in pediatrics is that those small doses of medicine can have a very big impact on small children, and children tend to be very sensitive to it. 0.1 milligrams can cause significant toxicity. The symptoms usually develop very rapidly within an hour. The symptoms are similar to a narcotic overdose in terms of apnea, bradycardia, hypotension, lethargy. Remember, COPS, the C is clonidine, so meiosis or small pupils. One of the things they wanted you to know in previous years was that it could cause transient hypertension. You would normally expect hypotension in these patients. Treatment, because it's such a rapid absorption and symptoms, usually gastric decontamination is usually not helpful unless there's other ingestions. What you want to do is get a blood gas to evaluate their blood gas status in terms of their acidosis, and supportive care, intubation if necessary if they're apneic, blood pressure support in terms of fluid and in terms of dopamine or pressures, immunosuppressors. You could, in previous years, we talked about using some Narcan or naloxone, that maybe that might have some effect. But in general, if you just provide standard supportive care for these kids, the ingestion will usually resolve within 24 hours. We did recently have an ingestion of clonidine in our within our area, and the mother put the child to bed after the ingestion, not realizing that the child ingested something, and found the child expired, and it was a very unfortunate case. But clonidine is one of those things that can be a very significant ingestion. Cold medicines. They wanted me a few years ago to add this. I'm just regurgitating what the AAP and the FDA have, which is the AAP says no use in less than 6 years of age. The FDA says no use less than 2 years of age. Now, the advisory committee voted no use less than 6. But the official FDA word was less than 2. Well, what did the drug manufacturers do? Of course, no one's consistent. Do not use in children under the age of 4, I believe, is what you see on most of the bottles. The reason that there was a switch was lack of evidence for efficacy and toxicity. Here's the list of cold medicines that were commonly on the market and that were commonly used either single or in combination. Obviously, it has significant potential adverse effects in terms of tachycardia, apnea, significant dysrhythmias. And so these are the reasons why when they looked at the literature or looked at the data and looked at how frequently that these occurred, that they decided to make that move. I wanted to also just mention a little bit about complementary and alternative medicine, specifically herbals. Now, I cannot sit here it would take me 2 hours to talk about herbals in and of themselves in terms of the different herbals and the different effects they have. So I mentioned a few of the more common herbals that we see. It is a very common practice. Up to 50% of your patients may be getting an herbal, and here are a few of the side effects that they can cause. What I really wanted just to bring to your attention is there's little FDA regulation of herbals. It's difficult to determine the cause of toxicity because there's no standards in terms of herbal preparation. So what did they really get and how much is very difficult to determine sometimes. I just wanted to key you in. You should ask. One of the things you need to ask about is if they're on alternative medicines, and the effects, the toxicity effects that you may see may be due to the medicine itself, or it may be its interaction with the other medicines that the child is on. Well, let's move on. Going alphabetically, we're now at ibuprofen. Fortunately, with ibuprofen, side effects are rare. Greater than 400 milligrams per kilo can cause serious toxicity, so that's a pretty good dose. If you've got a 10-kilo kid, that's 4 grams. That's, 20 pills? So that's a pretty significant amount. Nausea, vomiting, GI distress is more commonly seen initially. Certainly drowsiness, lethargy, ataxia, some CNS effects. The big things have to do with coma, seizures, and renal failure in terms of whacking your kidneys. Now, it is fortunately fairly rare that you have a child who will ingest a significant amount of ibuprofen to have significant toxicity. The treatment for it is activated charcoal and supportive care. Monitoring the renal function is what you would most commonly want to do, along with the acid-base status. Iron ingestion. Common cause of serious toxicity. Very toxic drug. One that we commonly use in the home. Either you've got anemic children who have iron, you have iron at home, or worse, pregnant mothers who have iron tablets at home because they have a very large amount of elemental iron in them. Pathophysiology, there are two. One is iron is very corrosive to the GI tract. So if you have a very significant iron ingestion, you'll get a corrosive effect to the gastric and the intestinal mucosa. When it gets absorbed, it has a very negative effect on your metabolism, causing mitochondrial and cell dysfunction, causes capillary leak with third spacing and significant hypotension. A toxic dose of elemental iron is greater than 60 milligrams per kilo, usually can cause significant toxicity. The 20 to 60 milligrams per kilo is kind of the gray area where you may or may not see symptoms. Less than 20 per kilo is usually asymptomatic. Well, iron has a very similar course to acetaminophen, and I've laid out that course there. The first stage is the GI stage, which lasts 30 minutes to 6 hours. That's where you get the nausea, vomiting, abdominal pain. You'll actually get bloody diarrhea or hematemesis for very large ingestions, and this is due to direct damage to the GI mucosa. You'll then have a little bit of phase of stability, 6 to 12 hours, and then you'll have significant systemic toxicity where you'll get significant cardiovascular collapse and severe metabolic acidosis. You go on to develop hepatic toxicity, and then if you survive with supportive care, you may get GI and pyloric scarring later on down the road as this direct damage to the mucosa will then heal and scar. I put a mnemonic there just to help remind you of the stages, and it's iron, which is indigestion, which refers to the GI stage, recovery, and then stage 3 and 4 is oh my gosh in terms of that's where everything goes to heck, and then narrowing. Evaluation of iron toxicity. I mentioned a deferoxamine challenge because in the, quote, old days, that's what they recommended. You would give someone an IM injection of deferoxamine, and you'd look for a vin rose urine. This is supposed to be my vin rose urine there, which would be the complex that's excreted in the urine. Unfortunately, that's a very unreliable indicator, and obviously we have much better tools now, specifically iron levels. Radiographs, not helpful in liquid preps and in chewable vitamins. Sometimes they're not visible on the radiograph. Prenatal vitamins usually are visible on radiographs, so a radiograph may help you confirm the ingestion. A iron level at 4 hours is the best way to determine whether or not you've got a significant ingestion. Less than 350 micrograms per deciliter usually is minimal toxicity. 350 to 500 you may have GI symptoms, and greater than 500 you look to have the more severe symptoms. How do we treat iron toxicity? Supportive and symptomatic care. Consider, I didn't mention whole bowel irrigation. That would be one time when you might want to consider whole bowel irrigation, where you're going to put an NG down and essentially irrigate the GI tract with Go Lightly. If there's a Bezor pills in the stomach, you can even consider endoscopic removal of those pills by your GI doc. We do have an antidote in deferoxamine. We give it IV. We give it for moderate or severe symptoms regardless of the iron level, so there's no nomogram to use. If you've got a huge number of iron pills on your abdomen, you can on your GI film, you can expect that your levels may be very large, and therefore you would consider treatment with IV deferoxamine. Things we don't want to do: ipecac the patient, lavage the patient. Usually those pills are very large. Activated charcoal does not bind iron. In previous years, they talked about, they toyed with the idea of using oral bicarbonate. That is not helpful. Oral deferoxamine, that is also not helpful. Opiate ingestions: morphine, heroin, codeine. Most cases present from drug abuse. Occasionally you'll see a child who will get into this, but most of the time it's drug abuse. Those symptoms can be drowsiness to coma, changes in mood, decreased GI motility, analgesia, respiratory depression. An unusual little factoid is that occasionally you can see significant abdominal pain, and that's due to increased colonic and biliary tone. Physical findings: you're going to see small pupils, respiratory depression, coma, GI decreased GI motility, hypotension from histamine release. Usually won't see significant tachycardia. And treatment is really ABCs, intubation if necessary, naloxone, and repeated doses of naloxone is necessary. I would tell you that if you see a question that you have respiratory and CNS depression, and you've got small pupils, I would be thinking opiate poisoning is probably the most common answer there that you should be looking for. Salicylate ingestion. Used to be very common, less common now, and that's because I think there's a little less aspirin in terms of used in pediatrics. Oil of wintergreen, which is a cooking substance, has a lot of a salicylate in it. It's actually a very toxic substance. Anti-diarrheal products also have salicylate in them. It uncouples oxidative phosphorylation. The acute toxic dose is greater than 150 milligrams per kilo. Acute signs and symptoms, again, this is something they wanted you to know in previous years. Nausea, vomiting, tinnitus is something that we associate with significant salicylate toxicity, hyperventilation, respiratory alkalosis, and then with serious toxicity, they can have fever, agitation, confusion, coma, renal failure. Death is usually in these patients from pulmonary or cerebral edema and electrolyte imbalance. Well, what do? We serially monitor levels every 2 to 4 hours. You can get blood gas, electrolytes, coags. Treatment, activated charcoal, aspirin pills have been known to form Bezor in the stomach, so we actually, in this case, consider multiple doses of charcoal. If you do have a Bezor, removal or possible gastric lavage. Aggressive fluid rehydration, these patients will get dehydrated. Replace your bicarb and replace your potassium in your fluids aggressively. Raise your urine pH with IV bicarbonate, enhances secretion of salicylate, so they sometimes will go on a bicarb drip. If the patient is significantly toxic enough, they will consider hemodialysis as a possibility. There used to be a nomogram, just like there was the Rumack-Matthew nomogram for acetaminophen. There used to be something called the Doan nomogram that they use for salicylates, and they don't use that. That's no longer recommended to be used anymore. Well, we're getting to the end of our alphabet here. We got tricyclic antidepressants. Onset of symptoms usually is within 2 hours. Major complications within 6 hours. Symptoms usually occur within 30 minutes to 6 hours. In children, CNS effects are more prominent. Lethargy, agitation, seizures, coma. You certainly can see tachycardic effects or cardiovascular effects in terms of tachycardia, hypertension or hypotension, widened QRS, prolonged QT. That's the classic finding for EKG that you want to know for tricyclic antidepressants. What you really should know also, though, is that you can get multiple different cardiac conduction defects with tricyclics, not just the widened QRS. How do you remember all this? Tri-CA is what I remember. Coma, convulsions, cardiac dysrhythmias, and acidosis are the symptoms I'd associate with a TCA ingestion. The workup, these patients can become hypokalemic. You want to make sure you get a BMP. Your standard for an adolescent, you'd want to screen for pregnancy, urine toxin or urine screen for other toxins, and then I would get my other drug levels, because a lot of times, at least for an adolescent, if this is a suicide gesture or attempt, you're going to want to look for other co-ingestions. The treatments, ABC, charcoal. This is a tricyclic. This is also an ingestion that we will consider alkalinizing the serum with sodium bicarb to prevent dysrhythmias. We generally recommend treating the dysrhythmias with lidocaine. And for the younger child, you should remember that if you are going to prescribe, let me rephrase that. If a patient is going to go on tricyclic medication, and there is a younger sibling in the household, you put that younger sibling at risk for an ingestion. And so one of the dangers that they wanted to know in the past was this in terms of prescribing tricyclics to teenagers. Well, I'd like to move on and talk about environmental ingestions now that we went through the drug ingestions. Specifically, carbon monoxide is the first one. Colorless, odorless gas. Carbon monoxide reversibly binds to one of the hemoglobin's 4 O2 binding sites. This impairs O2 release at the tissues. In other words, the carboxyhemoglobin hangs on to O2 that would normally be released to the tissues. In other words, it shifts the dissociation curve to the left. Essentially, the O2 carrying capacity is limited, and the O2 release to the tissues is limited. And here's the graph that shows the partial pressure of O2 and how at various saturations of hemoglobin, how that will be negatively affected. So symptoms: headache, dizziness, nausea, malaise, i.e. flu symptoms, and one of the worst ED nightmares is for family to come in the middle of the winter using a space heater. You don't do a full history. The whole family's got the flu, send them home, and then reports, of them family being found dead, a day later from a malfunctioning space heater. So you have to be clued into the fact that this sometimes can look like other other diseases and be aware of that. Some patients may show vomiting, ataxia, seizures, coma, death. Obviously, those patients are fairly significantly affected. There are few specific physical findings. The cherry red skin is usually not of diagnostic value. Well, laboratory evaluation, you do a carbon monoxide concentration greater than 15 to 20%. You will usually begin to be symptomatic. Pulse oximetry, by the way, in these patients most likely will be normal. Treatment is high flow O2. That's what you have to remember for carbon monoxide exposures. A half-life in room air of carbon monoxide in your system is 5 hours. A half-life on 100% oxygen is 30 to 90 minutes. Cardiac monitoring is important in these patients. You want to correct anemia to improve your oxygen carrying capacity. Certainly treat any metabolic acidosis that occur. People certainly think, and the more glamorous thing with carbon monoxide poisoning is hyperbaric therapy. While we still use hyperbaric therapy, it's a little bit of a controversy as to which patients you should, quote, dive. Certainly pregnant patients and neonatal patients may benefit from hyperbaric therapy. You should also, if this is a carbon monoxide exposure from a closed space fire, the other thing you have to consider is other exposures, i.e. cyanide from the plastics that have burned. Well, caustic ingestions. Alkali agents and acidic agents, they wanted you to know very specifically about what could cause these type of ingestions. So specifically, oven and drain cleaners in your home were a risk for alkali agent exposure. Hair relaxer, bleach, automatic dishwasher detergent. The one that we've seen most common, I shouldn't say most commonly, but the one that we've seen recently I was talking about at lunch was the laundry packets they now have that are in those plastic, and they have kind of like a liquid in them, a brightly colored like orange or green liquid in them. And we've actually had some kids who've had, generally laundry detergent in and of itself isn't a big deal, but we've actually had inhalation of it because the kids are chewing on it and it explodes and they inhale it, and they came in with actually stridor and hoarseness. So anyway, alkali agents usually are tasteless. Can cause very significant liquefaction necrosis, which is severe and deep. Usually we think about the GI tract, usually not the airway, although it can be, but usually the GI tract. Of note, 5% bleach, household bleach is 5%, and the reason it's 5% is not only is that a dose that's reasonably effective in terms of cleaning or concentration that's reasonably effective while cleaning, but it's also only an irritant, meaning that 5% bleach, which children may ingest, will sometimes cause some GI symptoms, but it's usually not going to cause very severe burns. Moving on to the acidic agents, toilet bowl cleaner, grout cleaner, rust remover, metal cleaners. For some reason, they wanted you to know about gun bluing, which helped keep the metal nice and blue. And if you've got guns, those are all very acidic agents. They're very bitter. Fortunately, they cause a little more superficial burns. The mucosa is a little more resistant. You certainly can get thick ascar formation. They did want you to know in past years that hydrochloric or sulfuric acid actually could cause minimal oral burns, and you can see significant lower GI burns or significant gastritis. And so just because you see no oral burns doesn't mean that the child isn't at risk for significant burns elsewhere. Signs and symptoms are pretty straightforward. You're going to see drooling, refusal to drink. You may see, in terms of physical findings, you may see the burns. They're not going to want to eat. If there was a respiratory exposure, you may see some stridor and respiratory distress. The child, if it's old enough, may complain of chest or abdominal pain. And in very, very significant ingestions, you can get hypotension and metabolic acidosis. Well, the workup. If you're completely asymptomatic, usually that means there's little or no injury and there's really nothing you need to do. But you do need to remember that just because the patient doesn't have oral lesions doesn't mean that they can't have a severe esophageal burn or gastric burn. Those patients, again, should have other symptoms, though. They should have chest pain. They should be refusing to drink, etc. So your standard workup here in terms of chest x-ray, belly film, lights, CBC, and in terms of treatment, obviously if they had clothing that was contaminated, you want to remove that, rinse the patient's skin. For those patients with respiratory distress, early intubation. I included this because Nelson's mentioned it, and that is acutely dilute with water or milk. Now, usually we don't do that, but it was in Nelson's. I would normally recommend keeping the patient MPO. IV, and don't forget analgesia. If the patient has burns, these are, even though they may not be visible, they're significantly uncomfortable. Usually for those patients that have significant burns with the caustic exposure, you're going to want a scope to determine the level and significance of the burn. Admission to the hospital for complications. Usually we don't treat with steroids. That's been discussed in the past. Now a couple of caveats. We do not want to neutralize the burn. So if someone took acidic, we don't want to do this chemistry experiment where we would give them some bicarb and kablooey. No gastric lavage, no activated charcoal. There really isn't any other treatment other than supportive. Complications, obviously, the burns can lead to, besides necrosis and esophagitis, if they perforate, you can get significant mediastinitis. When they heal, they can form strictures, so later on they may need to be evaluated with an upper GI. A specific note about hydrochloric and sulfuric acids, we talked about they can cause severe gastritis, all without a mouth burn, so you need to be very careful about those patients, and if they have any symptoms at all, they need to be scoped and evaluated. Moving on to foreign body. Now, I did pick a specific foreign body consistent with the Dallas area here. Generally 6 months to 3 years of age. Those are the kids that are putting stuff in their mouth and choking on them. Coins are the most common thing that we see. It can be lodged in three areas. One is the upper esophageal sphincter, the aortic arch here, and then the lower esophageal sphincter. Those are the three areas. 30% of them can be asymptomatic. You should take all seriously. Drooling, dysphagia, most common symptoms. Sometimes if it's up high, you're going to get choking, gagging, vomiting. Obviously, if it's in the airway, you're going to get cough, stridor. Patient may just complain of pain in the neck, throat, or chest. Well, diagnosis. If it's a radiopaque object, obviously a radiograph will help you here. Generally, coins will be flat on AP if it's in the esophagus. If it's in the trachea, it's supposed to be on edge. Radiolucent objects are a little more difficult. You can consider CT or a contrast esophagram. The other thing is some people just move straight to endoscopy to look down there to see if there's anything there. There have been, when someone's ingested a coin and asymptomatic, there is reports of literature of people using metal detectors to see whether or not it is in the stomach. I'll just include that as a point of interest, not probably a board question topic. Well, treatment options. Endoscopy is the gold standard, certainly urgent for patients with respiratory symptoms or sharp or objects that are sharp, such as that object that was in the esophagus. May observe for 24 hours and repeat the radiograph if it is in the middle to distal esophagus. The patient has no symptoms. The object is been there for less than 24 hours, and it's a blunt object. So if it's just about ready to pass, you could consider observation. There's lots of other ways that people in other institutions sometimes will remove these. There's balloon catheter removal under fluoroscopy, where they take a balloon catheter, put it in there, and blow up the balloon and pull it out. They push it into the stomach using it as bougie dilator. There's discussion in various literature about using glucagon or meat tendinizer. Those are things that you should not do. One note about button batteries. This is a significant one. A button battery, either ingestion, if it's not in the stomach, ingestion or button battery in the ear or nose or whatever, that is a significant emergency. It can cause damage by caustic leakage and by electrical current. You may, if you take a radiograph, you're going to see them. You will see a little double ring there a lot of times. You can get mucosal injury within 1 hour, and for an esophageal one, you can get full thickness injury within 4 hours. So these patients require immediate attention, immediate removal. Now, if it's in the stomach, most of the time we'll have them monitor the stools. We'll repeat the x-ray about every 3 days to make sure that it is passed. But if it is in the esophagus, you need to call up your subspecialist, whoever does your scopes, to have them come in and remove this urgently. It's not something you're going to want to put in the hospital and take care of the next day. The same is true if you've got it in the ear or if it's in the nose. Ethanol ingestions. I do think it's important to talk about ethanol ingestions so that you're all aware of the side effects and symptoms that you're going to have after you get done with your boards. Ethanol is found in multiple products in the home, mouthwash, perfume. Obviously, even if the family's having a party and the drinks are left out, they can ingest them that way. In younger children, CNS depression is the most common thing that we see. Obviously, significant ingestions, you can have vomiting, nausea, slurred speech, ataxia, respiratory depression. Hypothermia is something I'd remember for pediatric patients. And for young children, I'd also remember that it can cause hypoglycemia. Remember that, hobbies. Hypoglycemia. And the reports are for ethanol ingestions, up to 10 to 22% of patients less than 5 years of age will be hypoglycemic. Ethanol levels, the way we diagnose this, fairly standard. You can use an increased gap. That would be for other types of alcohol ingestions, not ethanol. Treatment is ABCs, IV fluids. You treat the hypoglycemia. If they're hypokalemic, you want to treat that. For ethanol ingestions alone, we do not recommend it activated charcoal. If it's an adolescent who may have a co-ingestion, depending on the patient's mental status and concern for other drugs and what they may be, you would consider activated charcoal. Hemodialysis for ethanol ingestions, rarely used. You need to make sure, since they're hypothermic, you need to make sure if they may be hypothermic to apply rewarming measures. And you also, especially for adolescents, if there is an ethanol intoxication, there may be other co-ingestions that the ethanol is masking, so you want to make sure you screen for other ingestions. Ethylene glycol, found in radiator fluid, antifreeze, coolants. I had a ethylene glycol ingestion a couple of years ago. He actually says radiator fluid tastes rather good. I didn't realize that. Never tasted myself. Metabolites are toxic. That's the problem with ethylene glycol. Again, this has stages in terms of nausea, vomiting. Again, a GI theme here. The second stage, which occurs in about 12 to 36 hours, is tachypnea cyanosis. You can get pulmonary edema, ARDS, death, and then in a couple of days you can develop cerebral edema. Renal failure is one of the more common things we worry about with these ingestions. Diagnosis, increased osmolar gap, so a greater than 10 gap. I mentioned that before with ethanol. A greater than 10 gap identifies unknown alcohol ingestions. Urine actually for ethylene glycol may fluoresce under a Woods lamp. Treatment. Ethylene glycol found in the garage. Charcoal of little value. Treat the metabolic acidosis with sodium bicarb. You treat if they're hypocalcemic, which is another side effect. You can treat that with IV calcium. And then antidotes. There are two antidotes. We used to use IV ethanol, real pain to give, real pain to monitor. We now have fomepizole, which has fewer side effects, easier dosing. The only problem is it's just more costly than the ethanol. And if necessary, these patients can be hemodialyzed. If you have an inebriated patient, one of the things you should think about is if they don't have an alcohol level, think about ethylene glycol because the presentation of the ingestion is very similar. Hydrocarbon ingestions, mineral spirits, kerosene we see during the wintertime, gasoline we sometimes see during the summer. Toxicity is due to low viscosity, which leads to pulmonary aspiration. That's what's most commonly I see. Now, there's various other hydrocarbons that have other significant toxicities. The one that I mentioned there is carbon tetrachloride, which can cause liver toxicity. Clinical findings for respiratory, obviously you're going to get a lot of respiratory symptoms. So coughing, gagging, choking, tachypnea, you may get some wheezing or respiratory distress. They may have some very mild CNS depression with a hydrocarbon ingestion, may develop fever. In terms of laboratory findings, you may see a leukocytosis that would not be unexpected. Chest x-ray findings may be delayed for up to 24 hours. So just because the initial x-ray is negative doesn't mean that later on they aren't going to have issues. So how do we treat these exposures? Dermal contamination, again, remembering to keep yourself safe, clean off the skin. Observe for 6 hours and discharge if the patient has a hydrocarbon ingestion and they don't have symptoms, and they've remained without symptoms, and their x-ray is normal, and they have a normal O2 set. So essentially, if he took a swig of gasoline and he comes in without a history of coughing and he remains asymptomatic, not tachypnic, not coughing, and his x-ray is after 6 hours is negative, you can send that patient home. If they're symptomatic at any time, or if you have a finding on chest x-ray, those patients need to be admitted to the hospital for supportive care and observation. I've listed here the obvious things that don't help. Ipecac, again, gastric lavage, again, found in the garage, not helpful. Activated charcoal, or I'm sorry, steroids used to be discussed as a possibility, usually not helpful, usually don't start prophylactic antibiotics. Organophosphate exposure, specifically pesticides. The problem here is that organophosphates bind to cholinesterase, leading to excess acetylcholine. The bond can become permanent over 2 to 3 days. Weeks to months are required for the regeneration of these enzymes, so it can be a real problem. Thanks to the Department of Washington Health Department, this is your normal pathway where acetylcholine goes over and stimulates your receptor. You normally have acetylcholinesterase, which breaks down your acetylcholine, and therefore you no longer are stimulating your postsynaptic neuron. In organophosphate poisoning, what happens is the organophosphate binds to the acetylcholinesterase, and therefore you get continued postsynaptic stimulation. So symptoms. Remember, we talked about the anticholinergic crisis. This is now cholinergic crisis. So dumbbells, and it's somewhat the opposite. Remember, we talked about decreased urination and sweating. We have diarrhea, urination, meiosis, so small pupils, bronchorrhea, emesis, lacrimation, salivation. Dumbbells is the mnemonic for those. The symptoms certainly can vary by age. Children are more likely to present with the altered mental status, which is on the right side here, coma, confusion. They may present with seizures. They may not present with these classic findings. There's not a lot of laboratory help for you. You can get a RBC cholinesterase activity, which can confirm the diagnosis, but that takes some time to come back. Treatment, protective clothing for all caregivers. This is specifically one that you want to make sure you protect yourself first so that you don't also drop while caring for the patient. Of note, latex gloves are not protective for this type of exposure. ABCs, remove clothing and decontaminate skin with soap and water. Antidotes. These patients may require very large doses of atropine. You can repeat them until effective. 2-PAM is also a antidote that can be used in the mass destruction poisoning kits that they have in various cities. There's a lot of either atropine or the 2-PAM. Benzodiazepines are used for CNS symptoms if the patient's agitated or has seizures, and the symptoms can persist for weeks without treatment. Another topic that they wanted me to mention was plant exposures. And just like herbal medicine, this is a very, very broad topic that it's very hard to get your hands around. I just wanted to mention, if I have a plant exposure, I call my poison control people to help me out. I'll take a picture of the plant or the leaf and send it to them to have them help me identify what the plant is. Fortunately, most plants don't have symptoms. I did list a few here that do cause and their symptoms that they cause. Specifically, a peace lily usually is just a GI irritation or some burning of the mouth. Pokeweed can cause irritation of the skin and the GI tract. The poinsettia and mistletoe and holly can cause some mild GI symptoms. There was a story going around, that at Christmas time that these were extremely toxic plants, and they are not. Dieffenbachia and philodendron, again, can cause oral pain. That's a very common houseplant. If you have lily of the valley, that's one that you might want to remember. That can cause a digitalis-like toxicity. The very final one I want to mention was lethal mushrooms. They tend to cause liver toxicity, and their symptoms are generally late, so that you have the ones that are not liver toxic usually just cause some very mild GI symptoms very early, and then the toxic ones cause the liver toxicity later. I do have an unknown. 2-year-old visiting grandparents' house. This afternoon she took an early nap, and now they can't wake her up. She's transported to local ED. They don't have any history that they know of. Pulse is 130, respiratory rate is 10, BP is 85/45, SAT is 85%. She's responsive to pain only. Pupils are 2 millimeters, no abnormal breath odor, slow, shallow respirations, no signs of trauma. So, if we're talking about toxins here, and obviously she could have been a victim of abuse, et cetera, but just in terms of toxins, the most likely toxin to cause this scenario is, and press your button, either organophosphate ingestions, opiate ingestions, phenothiazine ingestion, ethanol ingestion, or tricyclics. And remember, I talked about respiratory depression, meiosis, got to be thinking about altered mental status, got to be thinking about narcotic overdose. So opiate ingestion is the most likely cause. I now move on to my next topic, and that was we finally plowed through all of that, and I do want to just add now a little bit of humor. Top 10 ED chief complaints, and I've presented this for several years. This is from the literature, if you can believe that. I do this with respect in terms of I love taking care of my patients. I don't care if they come to the emergency department. I do have a little enjoyment occasionally for some of the things that they come to the ED for. So someone actually put this in the literature. Drank the dog's milk from the dog's nipple. Needs a circumcision because his tonsils and adenoids are so big. Problem with his manlyhood here. Sprayed hairspray all over the bathroom, then threw up from the smell. I thought that was a pretty good one. And baby is afraid of his hands. I don't even know. Like, what do you go in and do you like examine the hands, or what would you do? Okay. By the way, this is from Humor in the Peds ED by Douglas Nelson. Do want to credit him. Now I've seen this. Saw someone got hit by a car. I've also seen this one last year. Placed tooth on the pillow, now lodged to the right ear. Yeah. Has been straining his anus muscles. Okay. I also have seen this one. Piece of bologna stringing hanging from the anus. Has anyone else seen that? Like they come in and, it's a $100 copay, and you go in there and go, well, yeah, and you just pull it out. And thanks. Can't find the baby's birthmark. Again, well, let me check it. Maybe it moved. Yeah. Okay. Trauma topics. Let's see. I think you're going to talk about bites in terms of treat rabies and stuff elsewhere, or in terms of antibiotics and stuff elsewhere, dog and cat bites. But I did want to mention a little bit about rabies. Bats are the big carrier. Certainly raccoons is another big group. Skunks, foxes, those are the groups that you need to worry about. Dogs and cats can be a reservoir, so those are the most common exposures we see in terms of bit by a dog ran away. Now we got to worry about whether there was a rabies exposure. More importantly, rodents, squirrels, rabbits, rats don't usually carry rabies. So when they come in and say, he got bit by the hamster at the pet store, you usually don't have to worry about rabies. For rabies, for domestic animals, if the animal's not sick, they usually just watch the animal for 10 days. And if the animal doesn't become sick, then you don't have to worry about it. If the animal is significantly ill and the symptoms are consistent with possible rabies, then it's recommended that they euthanize the animal and they look at the brain to see whether or not the animal has rabies. That's for a domestic animal. For wild animals, they just recommend euthanizing the animal and testing for rabies. It's recommended that you contact your local health department. Rabies is not indigenous to every area in terms of what you see in your county. In terms of rabies therapy, rabies immune globulin into the wound and the rest IM. So you give as much as you calculate the dose, and you give as much as possible IM, and then you give much as possible into the wound, and then you give the rest IM. For the rabies vaccine, there are 4 doses, and this is why it's a pain for the ED at day 0, 3, 7, and 14. Now, it used to be they gave a 5th dose at day 28. Interestingly enough, little controversy a couple of years ago because they looked back and hardly anyone or very few people get the 5th shot, and no one got rabies. So they decided that 4 shots were okay. Not just a tip, not in the gluteus. They gave people vaccine in the gluteus. They ended up getting rabies, and so they recommend not in the gluteus. Of also note, bad exposure consists of bite, exposure to fluids, found sleeping in the room with a bat, or a bat in close proximity to a child. So, and you should take all of these seriously. I was telling a story of a patient who has Down syndrome, who has leukemia, who stepped on a bat that for some reason was on the ground, and we went through the normal stuff and gave him the normal stuff, and it turned out that the bat had rabies. So you should always treat these very seriously, especially if it's a bad exposure, because you never know when you're going to end up with a positive. Snake bites. 95% in the U.S. that are a problem are pit vipers, rattlesnakes, cottonmouths, copperheads. They have a triangular head, elliptical eyes, pit between the eyes and the nose. Pit viper venom causes tissue necrosis, vascular leak, and coagulopathies. It can also cause neurotoxicity. Children are a problem because they have a low mass. So, signs and symptoms usually develop fairly rapidly within 2 to 6 hours, can cause severe muscle pain, nausea, vomiting, weakness, fasciculations, coagulation abnormalities. Treatment. Most important thing is to identify species of snake. And so I love the story that we have where our triage nurse is at triage, and of course they brought the snake with them and pulled it out at triage. You should have heard the commotion. What the heck's going on out there? Immobilized extremity, wound pressure. You know, the old westerns they have where you have to, cut the wound open and suck out the poison is not recommended. No ice to the area. Generally IV line, coag, CBC, pain medicine if these are uncomfortable. Make sure you update their tetanus status because it's a puncture wound. And then the antivenin is available, and its use is based on the severity of the bite. So for those that are just puncture wounds but they don't have any other symptoms and the labs are all normal, they don't recommend treatment. For those that have moderate to severe symptoms, you're going to treat those. And then you have this middle ground where you may consider treatment, i.e. if you have a little bit of local swelling and you have some local pain but it doesn't seem to progress and you have normal labs, those are patients who I might use my poison control expert to help figure out whether I need to give therapy. Two other bites I want to talk about. One is black widow. The other is brown recluse. Let's talk about the black widow first. Red-orange or hourglass markings on the abdomen, found in barns, woodpiles, nests. The venom is a neurotoxin. So the things you're going to see is pain around the site, muscle cramping, chest tightness, vomiting, sweating, agitation, hypertension. Treatment for a brown or a black widow bite is usually supportive. Pain control, benzodiazepines. There is antivenin available if you have a very severe black widow bite. You can use antivenin. Again, I would use my poison control resource for that. They talked in the previous years about using IV calcium. That is ineffective. The symptoms, if you support the patient, the symptoms usually resolve within 24 to 48 hours. Now, the other insect or the other spider bite that you need to know about are brown recluse spiders, and these this toxin works differently in terms of it's not a neurotoxin. It is a venom that lyses the cell walls. So the symptoms is initially painless, and then you get a little pain around the site, and you'll get a hemorrhagic blister to a very large ulcer. So how I would remember or distinguish between these two is you remember neurotoxin and one causes an ulcer, one is a neurotoxin. The brown recluse, the recluse has a U in it. So think of the U in the recluse for ulcer, and you'll remember what the symptom complex is. Rarely you can get other systemic symptoms from brown recluse. Usually, if they have systemic symptoms, you admit them, but usually it's local wound care is the issue for a brown recluse bite. Now, I will have to tell you that just of note, and I'm sure you talk about MRSA elsewhere, but the most common cause of spider bite in my ED is actually MRSA. You know, they all come in saying I got bit by a spider, and it's a MRSA. Burns. Second major cause of unintentional pediatric death. Fire, scalds, flame, electrical, chemical. 18% of burns are due to abuse. Prevention is the key. Keep matches out of reach. Electrical plug protector. Set your water heater to 120 to 125. Now, I said last year I was going to revise this slide, and Tommy, you need to remind me this year. Extinguish flames, like someone's going to come into the office like still burning or something. I don't know why I still left that in there. Obviously, extinguish flames. ABC. ABCs, remove clothing, wash off all chemicals if there's a chemical burn, cover the air with the burn with a clean, dry sheet. For small burns, we recommend cold, wet compresses. For large burns, we use dry dressings. Hypothermia is a problem, especially in the pediatric patient, and so we don't want to use cold, wet compresses. No grease, butter, or ointment. That's what the grandmothers always want to use. Burn classification. First, second, third degree. There's talk of fourth degree. I'm just going to mention the first three. First degree or superficial thickness is superficial red, minor swelling, resolves within a week usually. Partial thickness burn, blisters or blebs, redness, pain. They're red, they're painful. The tissue underneath is perfused. May take 1 to 3 weeks to heal. And then finally, third degree or the full thickness burn, which is dry, leathery, waxy, usually is not painful because you've killed your pain sensors, may require grafting or healing from the edges of the burn. They want you to know how to be able to calculate burn surface area. So we're going to walk you through this. The best way to do it is actually an age-appropriate burn chart. If you don't have that, there are a couple of quick, easy, dirty ways to use it. Rule of palm for the smaller children, less than 9 years of age. So you take their palm, and that's equal to about the child's palm, and that's equal to 1% of the body surface area. So you can get an idea then of how much burn the child has. For the older children, you can use the rule of nines. The rule of nines is your head and neck is 9%. Each upper limb, so your right and left arm, is each 9%. The front of your thorax and abdomen is 18. Your back is 18, and then each leg is 18%, and then your perineum is 1%. So I want to walk through that for you in terms of a patient is a 12-year-old who sustained a burn from a house fire. On exam, he has a partial thickness burn of half of the front of his abdomen and chest, and incomplete involvement of his right lower extremity. The percentage of partial thickness burn is and you guys are all really good. 100% got it right, 27%. So minor burn care. First degree requires no therapy other than pain control, generally, maybe some skin moisturizer. Partial thickness, clean with soap and water daily. Debride large or painful blisters, antibiotic ointment, Acetaminophen, or sulfadiazine. Dressing changes once daily, although our surgeons will sometimes let them go a couple of days. Facial burns may be left open. Don't forget about tetanus update on all of your trauma patients that potentially could have tetanus exposure. And then you reevaluate every 2 to 3 days for all partial and full thickness burns. Sometimes these burns will progress. Obviously, after the burn care has been done, you need to make sure that you avoid sunlight while they're healing. That's for minor burn care. For major burn care, you're going to look at your ABCs first. So airway control, you should consider for, especially if there's possible upper airway involvement, early intubation. Consider carbon monoxide exposure for closed house fires. IV fluids for burns for greater than 15% body surface area. So it takes about 15% before you would want to consider IV fluids. There are various formulas out there. Various surgeons have various preferences, in which case you may see something different than the Parkland formula, but that's probably the most widely known one. And the formula is 4 mLs per kilo per percent body surface area for the first 24 hours. And the way I remember 4 is burn has 4 letters. Use Ringer's lactate. Half of that volume is given in the first 8 hours, and the other half is given within 16 hours. And then you should also add maintenance rate to this volume. So I wanted to calculate out what that would be. For a 10-kilo child for a 20% burn, 4 cc's per kilo per percent burn would be 4 times 10 times 20 is 800 cc's, and you want to give half of that, or 4 mLs, in the first 8 hours, and the other half in the subsequent 16 hours, and then add your maintenance fluids. Besides IV fluids, other things you want to do, make sure you give good pain control. Again, I mentioned about tetanus. When to refer. Certainly you want to be in a pediatric institution or burn center when you have greater than 15% body surface area. For full thickness burns, greater than 2%. For inhalation injuries, we're at high risk for complication. And then larger burns of high-risk areas, and those are the face, the hands and the feet, and the perineum. And then obviously if there's a concern for abuse. Just a note about another type of burn, electrical burns. Minor electrical burns, fortunately, with household current, most of them are asymptomatic and don't require significant evaluation. Minor cleansing and antibiotic cream. Of note, the one thing I wanted to mention was an extension cord bite, where you get burns to the oral commissure, to the sides of your mouth. Those need to be followed up with a burn surgeon because they can develop significant complication, either scarring or bleeding, and need to be followed by someone with significant burn experience. The other burn that can be very significant is a high tension or electrical wire burn. All of these exposures I would consider to be serious and admit. They can cause deep muscle injury, dysrhythmias, seizures, paralysis, ocular damage, fractures, renal failures. These are usually fairly significant injuries, and they can exhibit very little tissue damage, at least on the surface, and actually have fairly significant deep tissue burns. So these patients should all be admitted and treated supportively. Near drowning, major cause of pediatric injury and death, bathtubs, pools, open bodies of water. 40% of the drownings are less than 5 years of age, males greater than females. Pool safety is a big thing, and one of my hot buttons in terms of making sure that when you talk with your families that have a pool, that they have the standalone fence around the pool, self-closing gates, locking gates, pool alarm, pool cover supervision. Pathophysiology, laryngospasm, swallowed water, loss of consciousness, vomiting, aspiration 90% of the time. You get hypoxia, obviously terminal apnea. Circulation fails within about 3 to 4 minutes, and CNS injury in 3 to 5 minutes. And this hypoxic injury causes cerebral edema, which is the most frequent cause of death. One of the things of note is that when you're treating these patients, hyperglycemia actually exacerbates that brain injury. The other system we have to deal with besides the brain or the CNS system is the pulmonary system, where you can get pulmonary aspiration. Usually the aspirations are fairly small. We don't usually manage saltwater and freshwater drownings differently. They both can develop ARDS and significant pulmonary edema. Hyponatremia is uncommon. Hypothermia is common. Of note, patients who survived a drowning episode or near drowning episode have been in freezing water for up to 150 minutes, but the key here is freezing water less than 5 degrees centigrade, and they had a core body temperature of less than 30 degrees centigrade. Cold water that is not freezing is not protective. So the spring drownings that we'll get a rash of 3 or 4 of them in the spring from a creek or a pool that is just being opened. those are not freezing water drownings, and therefore they don't have any protective effect, and therefore we don't treat them differently than we do just a routine drowning. Well, treatments, ABCs, protect the C-spine if appropriate. Think about abuse. Think about a diving injury. Vomiting is common in these patients, so if they don't have their airway protected, cricoid pressure when intubating, NG tube. If you need to warm them up, warmed IV fluids, warm O2. You can warm gastric lavage or warm bladder lavage to get them warm. For most drownings, again, you don't need to completely rewarm them. For freezing water drownings, we usually like to get the core temperature about 32 degrees centigrade before we'll stop resuscitative efforts. For all the near drownings, even if the kid seems to be okay, they need to be observed for 12 hours. They may have an initial recovery period and seem to be fine, but then have some ARDS from aspirated water. And those symptoms usually are going to develop within 8 to 12 hours. Head injury. Common pediatric complaint. Most are not serious, require observation only. Symptoms, vomiting, lethargy, headache, irritability, behavioral changes, physical finding. I wanted to mention Cushing's triad. Impending herniation causes bradycardia, irregular respirations, and hypertension. Obviously, this is a fairly significant head injury. Other physical findings, you may just see a mild altered mental status. He's sleeping more than usual. He's not acting right. Obviously, an abnormal GCS at times. And you may see pupillary changes. And of note, they wanted you to know, at least in the past, that papilledema is actually a late finding, doesn't develop immediately. It may take hours to weeks to develop, so it's a late sign of intracranial hypertension. Obviously, when you're evaluating a head injury patient, infants, you should look for retinal hemorrhages, for abuse, look for other bruising, look for scalp swelling, and especially beware of non-frontal scalp swelling. So these, goose eggs we see on the forehead, I don't worry about so much. I do worry on other locations on the scalp. Should always palpate to make sure they don't have a step-off suggesting a depressed skull fracture. Other physical findings for the older child, look for signs of alcohol or drug abuse. You need to remember that just because there isn't signs of external head injury doesn't mean that they don't have significant brain injury. A couple of other points before we go on to how we evaluate these patients. I wanted to mention in the past they wanted you to know about temporal bone fractures and basilar skull fractures. Temporal bone fractures, usually you'll get some bleeding from the external auditory canal. You'll see a hemotympanum or blood behind the TM, hearing loss, facial paralysis. You may have CSF otorrheas or CSF leaking out of the ear canal. For basilar skull fractures, they want you to know about raccoon eyes, so you'll get some bruising underneath the eyes, or a post-auricular bruise, which is called a battle sign behind the ear. Both of these take hours to develop, so you may not see them acutely. Again, with basilar skull fracture, you also may see blood behind the ear and CSF otorrhea. For both of these, the best CT is the best for diagnosis. So you have a child with head injury. Who do you neuroimage? We're really in a quandary here. We have a significant push to limit our radiation exposure, especially to small children, but yet small children, infants and small children are poor historians, obviously, more difficult to evaluate, frequently asymptomatic, and obviously you may not be getting the whole story, and there may be potential for abuse and more significant injury than you thought. So I've listed 3 different categories of patients here. The first is this: you don't want to CT scan these high-risk patients, and this is taken from a prospective cohort study in the Lancet in 2009, and there are various different recommendations and different studies out there. These are the ones that I find to be the most helpful and used. So for your younger kids, certainly those that have focal neurologic signs, so those less than 2 with an acute skull fracture, if they have depressed mental status, irritability, fontanelle changes, persistent vomiting. So if they vomit once, and they otherwise 4 hours ago or 6 hours ago and have fed several times since then and been completely fine, I may not scan that patient. But the persistent vomiting I would be concerned about. Seizures, certainly those patients less than 2 that had definitive loss of consciousness. If you have a suspicion for a child abuse or an underlying condition that would predispose you to a problem, i.e. an AVM or a bleeding disorder, all those kids deserve scan. Now, if you're a little bit older, then we hone down a little bit more. You definitively need to scan those that have focal neurologic signs. I think that's a pretty straightforward. Skull fracture, especially a basilar skull fracture, altered mental status, seizures, prolonged loss of consciousness. So if you're 30 seconds or if you're 5 seconds or 10 seconds, you don't necessarily have to scan all those patients. You have a second group who, depending on the family, your capabilities in terms of what you can do if you're in the ED or your office, the availability of CT, the reliability of the family, whether they have a phone, transportation, etc. You may want to observe these patients in your office or at home, or you may want to scan these patients. So this is your intermediate group. And again, the symptoms are very much the same. Now, they do have some historical things there in terms of high-risk mechanisms: falls greater than 3 feet, patient ejection in a motor vehicle accident out of a car, a rollover, impact injury, or death in the vehicle. All those put a smaller child at little higher risk for a intracranial problem, and therefore deserves a scan. I do want to also note scalp hematoma, especially non-frontal. Those you should key into. I might need to get a CT scan of those patients depending on the rest of my exam, the family, etc. A skull radiograph can be done on some of these patients to be a screen, and if it's positive for a skull fracture, go ahead and scan them. But you should consider CT. Unwitnessed trauma in the less than 2 years of age, because you don't know how severe it was or what happened right afterwards. And less than 3 months of age, really high risk, I would consider scanning those patients. And then the older group, it's vomiting, questionable loss of consciousness, headache, high-risk mechanism. You may want to consider either observation or scan. And then you have those that you don't need to neuroimage. So those less than 2 with a normal exam, no seizure, no persistent vomiting, no suspicion of abuse, and no high-risk conditions, those you don't need to scan. And I've listed essentially it's no in terms of all the symptom complexes there. So those are your 3 groups. I have the group I absolutely need to scan, this group that I don't need to scan, and then you got this middle group you got to figure things out. We used to use skull radiographs as a determinant to help us sometimes guide whether we need to scan or not. Most kids with minor head injury don't need anything. They don't need CT. They don't need skull films. Occasionally, we do use the skull film that if it's positive, we'll go ahead and scan the patient. Just a reminder that if the skull film is negative, that doesn't mean that the patient doesn't have a significant intracranial injury. And if it's positive, it also doesn't mean that they have a significant intracranial injury. Well, treatment for head injury, most of the time it's observation. If they have significant symptoms, you do your ABCs, mannitol and 3% saline for signs of herniation. The most important thing is prompt CT in those select patients that may be at risk for injury. I've shown here an epidural hematoma, which is the concave or the convex presentation, and then a subdural hematoma, which is the concave presentation. Moving on to a different type of head injury, concussions, which is a traumatic alteration in mental status with or without loss of consciousness. A lot of attention paid to concussion status these days, especially for high school sports. Concussion can present with confusion, loss of consciousness, disturbance of vision, loss of equilibrium, amnesia, headache, dizziness. The most important thing is to perform a neuro exam, and asking about the game is more appropriate than asking about the name or the phone number. So if they're not in a game, ask about the most current events rather than some past history. The reason we worry about concussions is a second impact syndrome, where you have another injury after you have the concussion, which can cause loss of autoregulation and significant intracranial pressure. There are multitude of concussion guidelines out there. They all share a couple of things. They all differ in some things. They all share certain things. Certainly the patient needs to be the player needs to be asymptomatic before returning to play. So that's a standard in all of them. Usually if you have loss of consciousness less than 5 minutes, you have to be out a week after you're symptom free. So and most of the guidelines are consistent with that. And obviously, if you have more prolonged loss of consciousness, or if it's your second you've had multiple concussions, you're going to be out longer, whether it be a month, 2 months, or the season. MRI and neuropsychological testing can actually be two of the other tools you can help for your teenage athletes that have severe or multiple concussions in terms of determining where you need to go with them. Okay, I told you we had to do a hodgepodge of stuff. Laceration, they want you to know about certain topics, specifically irrigation with saline under mild pressure is the best form of cleaning for lacerations. It's not soaking the wound in saline or Shirklands. Updating your tetanus, don't forget. No topical skin adhesives in scalp lacerations or bite. Let gel is something that we commonly use. It's a lidocaine, epinephrine, and tetracaine. It's a gel that's fairly effective for forehead lacerations, scalp lacerations, chin lacerations. It's a topical, takes about 15-20 minutes to work. There are certain areas, because it has epinephrine in it, that you would not recommend, i.e. the fingers, nose, toes, and penis. One other special tip about lacerations that they want you to know in past content specs, and that is eyelid lacerations. If they, you have to be very careful. If they have a potential for a tear duct involvement, they should be referred to a ophthalmologist for repair. Couple of other referral recommendations. Vermilion borders, eye soap, the very easy ones that are just straight and very easy to put together, that seem to fall together very easily. But if they're complex, you're going to need a plastic surgeon or a suture expert to care for these, because if you don't get the line of the lip lined up correctly, it'll be very cosmetically noticeable. Hand injuries are a high-risk injury, especially a clenched fist hand laceration, i.e. a teenager gets in a fight and hits someone else, and they present with a laceration to their knuckle here. That is a high-risk injury because you may embed significant bacteria in the wound, and then when they flex their fingers, you've now deposited it even deeper. So those you want to usually not close and refer to a hand surgeon. Complications of lacerations include tendon lacerations, obviously have loss of function. You can get arterial or vascular compromise. Staph or strep are the most common causes for infection. Obviously through the shoe, I think Tommy's going to talk about in the ID lecture about Pseudomonas infection for those patients. You also can have joint involvement, which is then a complicated laceration that should involve a orthopedic surgeon. If it doesn't heal appropriately, and especially it's over a joint, you can have limited flexibility. And then obviously there's the cosmetic considerations in terms of scarring in those patients who develop keloids. A word about puncture wounds, high-risk wounds for infection in foreign bodies. Obtain a radiograph. Sometimes you need to obtain an ultrasound or a CT scan to look for that foreign body. Treatment is superficial irrigation. We tend not to use deep irrigation or very forceful irrigation. It's not helpful. We tend not to core the wound out. That's been recommended in the past. We don't usually repair these. We let them open. Prophylactics are usually, antibiotics usually aren't recommended unless it's through a very, very dirty wound or through the sole of a shoe. Again, tetanus needs to be updated. Well, we're on to the last section of the trauma here, musculoskeletal trauma. I want to talk about fractures and sprains. Salter-Harris classification, I've listed here Salter-Harris 1, 2, 3, 4, and 5. The mnemonic is SALTR, and the S for Salter-Harris 1 is separated, and for A is above, i.e. your metaphysis is involved. The L is lower, i.e. your epiphysis involved. And the T is together, so both the metaphysis and the epiphysis are involved. And then for Salter-Harris 5, the R is for rammed, where you have a compressed growth plate. These two, Salter-Harris 1 and 5, are very difficult to see on X-ray, and a lot of times your radiologist hedges on that. 2 is the most common fracture, Salter-Harris 2, so you'll see a metaphyseal injury there. Those actually heal fairly well, fortunately, and usually, unless they're significantly displaced, just require immobilization. 3 and 4, Saltair 3 and 4 usually require an orthopedic consultation because they can have significant sequelae and complications. The rule I use and tell the residents is if you suspect a fracture clinically, even if you have a negative x-ray, if they have open growth plates, treat as a fracture and x-ray the patient later. So i.e. immobilize the patient in a splint and then bring them back or have them follow up with their doctor and have them reevaluated in 5 to 7 days. So let me see here. So what type of fracture is this here? I don't have this as a question actually, but if you look at your Salter-Harris graph here, this is a Salter-Harris 2 that we have where you have a metaphyseal fracture here. Now we actually have a fracture here, but this is the one that I wanted to key on. This would be a Salter-Harris 2 fracture. A couple other types of fractures. Green stick fracture. You can see that, it's not the best, but if you look here, you have the cortex that's intact on one side, and on the other side it's open. And this is where the tension side, you have a fracture of the cortex, and then on the compression side, you just have a little bit of bending or plastic deformity, i.e. the fracture is really not complete through the bone. Clavicular fractures, common fracture in childhood, usually less than 10 years of age, middle portion, third portion of the clavicle. It involves most of the fractures. Usually they're falling on an outstretched arm or they have direct trauma to the clavicle. Neurovascular injuries uncommon. These usually heal really well. We used to sling these. We most of the time don't do that. We put them in, a figure of 8 strap. Most of the time now we just put them in a sling for comfort for a few weeks, and within 3 to 6 weeks they heal. A torus fracture is a compression fracture of the bone that produces a torus or a buckle, and this is one that we commonly see. It's most common in the distal radial metaphysis. It heals well after 3 weeks worth of immobilization. We still cast these at our institution. Sometimes some places will actually just put them in a little one of those little pre-molded splints, and they usually heal fine. Spiral fracture has a curvilinear course, and you can kind of see here that this goes and curves around the tibia here. It's common in toddlers, but you should certainly think of abuse if you have a patient who's not walking, especially if it's a femur fracture. The twisting motion that the patient may sustain while being abused causes that type of fracture. Distal humeral fractures. Supracondylar is the most common elbow fracture. They usually fall on an outstretched hand or elbow. I commonly see them in the spring with the monkey bars. We've got kids falling off the monkey bars and they'll fall on their arm or their elbow and present with a supracondylar fracture. A posterior fat pad, which hopefully you can see here, this gray area here is the posterior fat pad, increases your suspicion for a supracondylar fracture. These can have, especially if they're displaced, a high risk for complication. You can have brachial artery injuries, median and radial nerve injuries or damage, and these you need to monitor the neurovascular status and document the neurovascular status very appropriately. Fracture complications, neurovascular compromise, especially with, as I just mentioned, the supracondylar fracture, the humerus. The other things you can see, compartment syndromes, most common with tibial fractures. You'll see the fracture causes swelling, vascular injury. That can lead to, if you have a significant enough swelling and vascular injury, lead to ischemia because the tissue blood flow is compromised. Pulses may be normal, but pain is out of control or out of proportion to the fracture and is remote to the side of the fracture. So my hand is really, or my foot is really hurting, and it's their fractured tibia. Emergent orthopedic consultation is what you need to do there, so they can measure the pressure, and sometimes they need to do a fasciotomy. One other fracture complication. It's not really a complication, but it's occult fractures that are not present on radiographs, i.e. they're not evident and you don't see them. Clues include a clinical exam that is consistent with a fracture, persistent pain, gait disturbances in young children. So we see these toddlers who have fallen. We do the x-ray, it's negative. When I send those patients home, I say the x-ray is negative, but you need to observe him for 3 or 4 or 5 days. If he's still having symptoms, follow up with your primary care provider. Radiographs may need to be repeated at some point, in which case we may see some healing bone and then determine that there's a fracture. Subluxation of the radial head. This may be covered in another lecture. Nursemaid's elbow is the other common way this is referred to. 6 months to 5 years. Traction on a pronated wrist is the most common mechanism. So they're walking across the street and the kid tries to pull away, or they're walking downstairs and the kid starts to fall and the mom or dad pulls on the arm. The problem is that the annular ligament slides over the radial head and then is out of place. The affected extremity is usually held to the child's side, usually flexed a little bit and held to the child's side. There's usually not a lot of tenderness to palpation at the elbow, but if you try to do range of motion, the child will begin to cry. Radiographs, if you have a classic history, are usually not necessary. Reduction, there's 2 ways to commonly reduce these, either supination of the forearm with flexion of the elbow, or alternatively, you may pronate the forearm. You may hear a click. Sometimes they don't. Usually the child, if you've reduced it, will return to function usually within about 15 minutes or so. Shoulder injuries. Just a few points on shoulder injuries. Commonly seen more in the adolescent than the smaller child. The small child, we do see the clavicular fractures, but other than that, it's mostly a injury limited to the adolescents. Usually a fall on an adducted shoulder is the most often seen, usually in contact sports. You get tenderness over the AC joint here, acromioclavicular joint. Usually those, if they're minor injuries, we put them in a sling. If you have a major injury, they need to be, and major symptoms, they need to be referred to orthopedics for evaluation. Dislocated shoulders, again, very uncommon in prepubertal children. They usually fracture rather than dislocate. It's not real common in adolescents, but that's the group that we will see them in. It's usually anterior, and you'll see swelling and deformity of the shoulder anteriorly. Your radiographs can determine that you have a dislocation. I usually use some pain control and then traction, counter-traction. There's various ways to reduce these, but that's the most common method that I use, and usually is fairly effective. Sling and swath after you get it back in, and then orthopedic follow-up. Sprains. Injury to the ligament around a joint when it is forced to move in an unnatural position. It's a sprain. Be wary of the diagnosis of a sprained ankle in a toddler, because we don't see very commonly sprained ankles in toddlers. Usually the ligament is stronger than the growth plate, and usually they fracture rather than sprain. In older children, the ankle and finger sprains are the most common. Wrist and elbows are uncommon, so if you have a wrist sprain, I would be very careful about treating that. Maybe there's an occult treating it as if there's an occult fracture. Physical exam, tenderness is the most important. Obviously, you'll see swelling and bruising. Evaluate the neurovascular status, look for ligament laxicity, and make sure you do range of motion. They grade sprains in terms of grades 1, 2, 3. Treatment is standard in terms of rest, ice, compression, elevation, the standard RICE. Severe sprains require a splint for protection and comfort. Air splints can help. Those air splints can provide help provide stability. And for severe sprains, you also should consider, if the patient has open growth plates, whether they have a Salter-Harris 1 fracture. Moving on to, as I said, we're doing a potpourri of trauma topics here. Corneal abrasion, you'll see pain, tearing, photophobia, decreased vision. In a fussy infant, in the differential diagnosis, corneal abrasion is in that list. Diagnosis of the fluorescein dye in a Woods or slit lamp. An abrasion is transparent where an ulcer is opaque. Corneal abrasion is usually treated with just some topical antibiotic ointment for comfort. You can, while you're in the office or in the ED, apply a topical cycloplegic agent for pain in the office, but you should never send the patient home with those drops. And then the patient usually needs to be seen within 24 hours to recheck, and usually by that time, refluorescein shows that the patient is fine. So the recommendation is, again, don't use homegoing topical anesthetics. topical antibiotic ointment is appropriate. We used to pressure patch these kids. It's really found not to be effective, so most of the time I won't do that. When to refer to ophthalmology for eye injuries is something else that they want you to be aware of. Certainly penetrating globe injuries need to obviously be seen by the ophthalmologist immediately. We don't usually manipulate those. We just protect the eye by putting a styrofoam cup or something over the eye. Hyphemas need to be referred to the ophthalmologist. Sometimes they need to be seen immediately. Sometimes they can follow up the next day. A hyphema that we have here is blood in the anterior chamber, which is the picture there. Usually is from a blunt, occasionally a perforating injury, usually a blunt injury. You'll see a brighter red or dark red fluid level between the cornea and iris. Sometimes it'll just look murky if it hasn't settled out yet. These patients can be somnolent. They'll complain of a lot of eye pain. Treatment is usually bed rest, elevating the head at 30 to 45 degrees. Sometimes they need to be admitted to the hospital. The final group of patients besides penetrating globes and hyphema that need to be referred to ophthalmology is fractures of the orbital floor with eye muscle entrapment. So make sure if you have a facial injury, you do a good range of motion for the eyes to make sure that there's not eye entrapment. The final group is chemical burns to the cornea. Alkali burns are usually the worst, although acidic burns can be significant. Emergency treatment, remember, the solution to pollution is dilution, i.e. copious immediate irrigation with saline, local debridement, using the pH test paper to make sure that the pH is appropriate. Irrigate for mild cases 2 liters. You can even, if for severe exposures, up to 10 liters of saline or lactated ringers. The final group, and I mentioned this previously, lacerations involving the lacrimal duct, all need to go to the ophthalmologist. They wanted me to include some PALS information. I'm just going to go very briefly over this because I don't think you're going to need to know it in detail, but I have it here for reference for you. Remember that here is the CPR algorithm for infant, child, and adult. Remember that they're really concentrating on appropriate CPR in terms of compressions. For the three groups here, I just wanted to run through quickly. Pediatric bradycardia. If their heart rate is less than 60 and they have cardiac compromise, obviously CPR. If you have persistent symptoms besides CPR, you're going to need some IV epi, atropine. Consider your underlying causes. Why are they bradycardic? For me, most of the time, I've got to make sure their airway is okay because that's the most common cause that I see of pediatric bradycardia. For pediatric the pulseless algorithm, VFib or VTAC, want you to think about the shock CPR drug cycle, which I have listed here. The big change this year is that or the past year or two, is that instead of doing just 2 joules per kilo, we're marching up and you're doing 2, 4, 6, 8, up to 10 joules per kilo for VFib or VTAC. And then the pulseless algorithm, which is asystole, fairly simple, CPR, epinephrine, either IV or IO. You can still recommend intratracheal epinephrine is still recommended at a 10 times dose at 0.1 milligrams per kilo, and then repeat every 3 to 5 minutes. Well, those are the topics I was supposed to cover today. As I said, it's a potpourri. I did want to mention for poison review, 2% of the poison topic, the poison lecture, 2% of the questions are going to be on your test in regards to that. And for the emergency topics, the trauma topics, and the PALS, 3% of those questions on your test are going to come from that information. So I wanted to end with, again, another little piece of humor before we go. Impossible final exams. The first one is chemistry. You must identify a poison sample that you'll find at your lab table. All necessary equipment has been provided. There are 2 beakers at your desk, one of which holds the antidote. If the wrong substance is used, it has caused instant death. You may begin as soon as the professor injects you with a sample of the poison. The electrical engineering, you'll be placed in a nuclear reactor and given a partial copy of the electrical outlet. The system's been tampered with. You have 17 minutes to find the problem before you have a meltdown. But the most important, and I got to poke at my friends, the surgeons, the general surgery boards. You guys think you have it tough. You have been provided a razor blade, a piece of gauze, and a bottle of scotch. Remove your appendix. Do not suture until your work has been inspected. You have 15 minutes. And with that, thank you very much.